I will move forward to our next presenter, who is Emmanuel Mtava. Emmanuel Katama Mtava is an epidemiologist and public health professional with more than 10 years experience in reproductive, maternal, newborn child health, and adolescent health. So Katama works as a technical officer for community health in the USAID's Tawisha Pwani project, primarily employed by AMRO. So Emmanuel, the floor is yours.
Okay, thank you, Marion. Good afternoon, everyone. Yeah, my name is Emmanuel Katama. I hope you can all hear me.
Yes.
Okay, thank you. Maybe you can share the slides, Marion, please.
Yeah, on it, just a minute. Are you able to see my screen?
Yes, I'm able to see. Maybe you can start with the first slide.
Okay.
Okay, thank you. Thank you so much, Marion and team, for listening to me. So for me, I'll be able to present a model, which is a best practice abstract, which you have been implementing it in our project for USAID Tawisha Pwani here in Kwale County. Maybe you can go to the next slide. Yeah, so this model is using default tracing tracker shells, just targeting young adolescents mother to increase utilization of immunization services in Kwale County. As you can see, Kwale County has a youthful population with young people below 15 years up to nearly 47% of the total population. This is according to the KDHIS 2022. And this has an implication in the county development agenda. And for that reason, it's a very key strategy to try to understand how best can you able to reach this category of young adolescent mother with immunization services and other health services. Next slide. Yeah, so immunization default tracing for young adolescent mother has been a challenge in most parts of Kwale County and generally in Kenya. And this is because of the inefficient approaches, such as unstructured tracing of the defaulters. As you can see, adolescents are kind of unique in how they really are able to be found in the society. For example, moving from foster residential care to living independently as an adolescent is also one of the likelihood of you missing immunization, because when you become a young mother, mostly according to our cultural setup, we tend to live away from our families. Either you get married or you stay as a single mother somewhere else. That becomes also a challenging factor in terms of getting immunization services. Again, young mothers or teenage mothers have competing priorities. They have time, they need time to work, need time to go to college. Sometimes they manage their welfare and benefits. So all these factors actually makes them very difficult for their kids to get immunization. Then we have lack of proper tracking records and generally reactive default tracing in the community with community volunteers who are our primary actor. So most of our communities in Kenya, we use community health volunteers to do default tracing for immunization. And because of the tracking, the proper tracking records which are not structured, we end up missing the young mothers and the adolescents. And for example, you'll find that most of the young mothers, when they give birth in the society, mostly in the rural setup, they kind of leave their children or younger ones with their mothers, where then they go back to the town setup for maybe to just work or rather to continue their life. And because of lack of proper tracking record, we might end up missing immunizing this child. Sometimes the caregiver or the mothers of the adolescent mothers are older women who no longer have an interest in healthcare services. And this has really led to some of the defaulters for the young and adolescent mother. Again, we have CHVs who are not motivated because of the many processes and poor categorization of the defaulters, especially the young and adolescent mother. And this have been some of the main challenges which has really made immunization for the young adolescent mother very difficult. So this abstract basically highlights the use of targeted default tracing tracker shelves by the CHVs, or rather the community health volunteers, to increase utilization of immunization services among the young and adolescent mother. Next slide. Basically in Kwale, in a village called Lusangani in Kinango sub-county, we were able to pilot this intervention. And what we did first, before the intervention, CHVs will trace the young mothers or the adolescent mother just by chance when they meet them in their household visits. We understand that during household visits, the CHV just move door to door and they have targeted visits. So they might end up meeting this adolescent by chance, but don't really are not really able to categorize them. Such visits would also at times run through the default tracing registers and categorize the defaulters per antigen and timelines. But again, another challenge is that getting these mothers in the community was difficult. And the facility healthcare workers also had minimal information of the true status of the defaulters in the facility. As I said earlier, sometimes just a young mother or a teenage mother can just come deliver in the hospital, then they move away, and there's no track or rather information about them. So it was difficult to tell whether these are just true defaulters or rather they are just clients who are receiving services from other facilities. And for that reason, we came up with a model just to make sure you're able to track all these adolescent mother and be able to understand exactly where they are. Next slide. So this model was implemented from January 2022 to date, and we piloted with 30 CHVs who were trained and supported, and these CHVs were supporting 20 villages, which were initiated the model. So this model basically, it means that as you can see in the photo, just having a track shelf, and this track shelf, it was labeled per village. But the main target was the young and adolescent mother. So every village with the young adolescent mother, they had they had their shelves, so that now every CHV is able to man a specific shelf. So for example, CHV A has 20 young mothers in his villages, CHV B has 15 young mothers. And for that reason, their mandate is ensuring that every specific month, this young mother is able to get all the immunizations, be it for the children and also for themselves. So on a weekly basis, each HVs checks the cards sorry about those breakup. So what I was explaining is that this model identified each shelf per village. So CHVs was mandated by manning a specific shelf, and this shelf specifically had cards which were assigned to adolescents and the young mothers. And on a weekly basis, each HV checks the card just to make sure there are no defaulters. And if there are at any cost, then they have to make sure they're able to track this defaulter. So the good thing with this shelf is that they gave detail of every young mother who delivered that specific village, whether they travel or did not travel. They can actually be able to track the child and be able to make sure they get the immunizations. The next slide. So the model resulted to a lot of decreasing immunization, defaulters of immunization, as you can see per the graph. So it was also an easy tracing method whereby it really avoided a lot of paperwork, because now the CHVs know who to target. They had different categories of people, but the teenage mothers and the adolescents were one of the prior targets. Then also it motivated the CHV just to make sure they feel responsible for specific village. So there was a kind of a competition in a positive way that everyone wants their village to have every child immunized for all the immunizable diseases. Also, there was easy planning of interventions for the targeted young mothers in the specific villages. Next. So in conclusion, this model is a simple and low cost, very efficient, which also reduces time spent and also paperwork. It also enhances proactiveness. This means reminding the adolescent's mother and the children of their date due for immunization of their defaulters. And this somehow help the CHVs, to make sure they're able to target all the young mothers in the villages and the adolescent mother, hence making sure that we don't have gaps in terms of immunizable diseases. Again, what we also did that we identified some of the mothers who are very active in terms of uptake of services, the young mothers, just to be able to act as champions to support other young mothers. So among the teenage mothers and young adolescents, you should have mothers who are champions. They're able to actually follow up on their peers to make sure they're able to get immunization for their children. Again, they also are able to support the NC groups in the community just to make sure you're able to get. Yeah, sorry.
Okay, I'm Humphrey Boy. I just wanted to ask a question before you proceed.
Hello, can I finish first, then you ask a question, please?
Okay.
Please. So let's go to the next slide. Yeah, thank you. Now you can go ahead and ask a question. Humphrey, yeah.
Okay, I'm saying I'm Humphrey Boy. I'm a
Yes.
clinical officer.
Yes.
And I'm also a software engineer.
Okay.
So I've seen you are using cards as you're using cards like a shelf that you just presented.
Yes.
To check on your on the vaccination status of a few patients.
Yes.
Children's in Kilifi. You say Kilifi or Lamu?
No, Kwale.
Kwale, I mean.
Yes, yes.
So I was asking, in cases of disasters, for example, in cases of fire outbreak in the facility, what backup, how do you trace those patients just in case all the materials have been burnt down or something like that? Or just an emergency disaster that is, yeah.
Okay, thank you, Humphrey. That's a good question. So as I said before, this was a model, kind of abstract to see how we can be able to get to these young mothers. But again, as you really acknowledge, you're going to the world of technology. We want to digitalize this means so that now when we find that it has an impact, we can now actually be able to extend and digitalize it to all facilities. This pilot was done majorly in one facility in a specific village. And again, these cards are just temporary cards to follow up on the young mother until they graduate. So I think, as you said, your concern is true. We need now to see how best we can scale up these interventions to make it not technological or digital in a way that it can be able to operate from any specific point. Thank you.
So in line with the default trackers that you've talked about, how does it work?
So how it works is that if a young mother or a teenage adolescent come to the facility and they're able to get their NC profiles, profiling, then this mother is recorded and is documented in their permanent registers. Then now the nursing officer is able to generate a card for them just to be able to follow them up through their ANC visits and later on through their vaccination after they deliver at the facility. Now, these specific cards, they are manned to a specific CHV who supports a specific village. So for the tracker shelf, for example, each tracker shelf is identified by a specific village. For example, village A has a tracker shelf, village B has a tracker shelf. So the number of adolescents mothers within those shelves are manned by one CHV, who is mandated by on following up of all those young mothers just to make sure they're able to get all the antigens during their period of interaction with the health services.
Okay, so in case you go, a patient, a mother fails to report a child for immunizations.
Yes.
Just in case, and what are some of the complaints that they have always been issuing, and how have you guys been helping in those complaints as well?
Yes, so what usually happens now, in case this mother fails to come for immunization, is a defaulter. So the CHV now is mandated find out why did this mother default, I mean, for the child. So they go to the village just to look for the mother. So there could be many options. Either the mother just defaulted because of lack of transport, or maybe lack of a fare to get to the facility. We can organize targeted outreaches, or probably the mother defaulted because, God forbid, the child died. So we can also document that. Probably they transferred to another country or another village. We can also document that and make sure where they are, they're able to receive the services. Or rather, if it's a community issue, we can organize targeted activities like targeted community dialogues, just to make sure you're able to follow up. So in short, we can be able actually to track the reasons why the mother defaulted and also do actionable work at that specific point.
That's great. My question ends there. Thank you so much.
Okay, thank you, Humphrey.
Thank you so much.
I can see Liz.
I can also see a hand. Yeah.
Okay.
Okay, thank you. Thank you so much. My name is Elizabeth. I just wanted to add on to what Mr. Katama has presented. And also thank you so much, Katama, for the nice presentation. Basically, we are working together with Katama, but of course, for community health volunteers, it's a structure that is within the Kenya government, and they cover each village, and they already know their household. So once the mother is not able to come to the facility, the CHV is able to track that mother. And normally they do household mapping, whereby they're able to know where these mothers are, or whether they've gotten these immunizations or not, and they're able to update. The only challenge that we have with the model, currently the model is not automated, and that is what we are working on. We've started it on a small scale, and we are looking forward to digitalize it. And I'm happy to see that we have Humphrey here, who is a software engineer, who can also support us so that we see on how we can digitize this model so that it can be able to support the facility very well. And normally, the mothers are given a card where they are able to go with the card at home, and at the facility level, they also have registers where they keep. So that data for that mother cannot go to loss. Yeah, that is what I want to add on. Thank you. Over.
Okay, thank you, Elizabeth. Those are very good inputs. So thank you so much. Over to you, Marion.
Okay, thank you so much. Before we proceed, I also had a question. I'm keen to understand, in case there's data available for this, maybe in terms of a percentage. You say the model, you incorporated the model in 2022. So I'm keen to understand, previously, before 2022, has there been a significant increase, and what's the percentage in terms of people, the young adolescent mothers who received immunization services?
Yes, thank you, Maron. Maybe you can go to my slide on the data, because this is a data which we are able to retrieve from the KHIS. And before the interventions, there were maybe you can just, yeah.
On key lessons learned?
Yeah, key lesson learned, yeah.
Okay.
So before the intervention, if you can look at some two graphs, of those immunization defaulters. I mean, the one colored in blue, the line defaulters referred, and those defaulters who reported. So during the period before, this is from 2021 July, I took that data, you could see there were high number of defaulters, highest being 90. Those who are they were reported, and those who are referred. So now, as the year went by, this is from the KHIS, so you see the defaulters reducing until by the time it is July 2022, it is zero. They're no longer defaulters. So this means that all the teenage mothers or the young mothers who are able to have children, they have all their children scheduled for immunization. They're actually immunized, so they're no longer defaulters. So this data also has previously 2021, then on the move on, it goes back to zero in 2022 as until now.
Correct. Thank you so much for that. Before we proceed, any other questions for Emmanuel? Okay, I'll